Dr. Arvind Cavale will be speaking to us. Dr. Cavale is a clinical endocrinologist, a researcher, instructor. He's a solo practitioner from Bucks County, Pennsylvania. His practice focuses on a strong patient relationship, attention to detail, combining human ingenuity with appropriate technology. He continues to work every day to help physician colleagues remain independent in practice, as well as strong patient advocates. Dr. Cavale?
Hello, everybody. My name is Arvind Cavale, and I am a clinical endocrinologist in solo practice in southeastern Pennsylvania. Today, I will be talking about what I call path towards freedom in medicine. And this is based on my lessons learned from working with the anti-MOC movement. As you know, MOC stands for Maintenance of Certification, which is a program designed by the American Board of Medical Specialties. I'll start out with my primary mission, which is to reestablish and strengthen the physician-patient relationship, to recognize the central role of the patient and his or her physician in the healthcare universe, to identify real impediments to achieving the above goals, and finally to accept our duty to be unfettered patient advocates. I'll begin with giving you some description about how the anti-MOC movement started and progressed as a grassroots movement. In the early 1990s, the American Board of Medical Specialties introduced time-limited board certification with a 10-year recertification cycle. Prior to this, all board certificates were lifelong board certificates. But 10 years later, this recertification was converted into a maintenance of certification process. Give it another 10 years, and more onerous patient and peer review requirements were added, and this created more problems for certified physicians. In 2010-2011, a couple of physicians, namely Drs. Paul Kempen and Ron Benbasat, recognized that MOC was becoming essentially mandatory without any proof of merit. Subsequently, Dr. Benbasat, on his own, established a website, www.changeboardresearch.com, and started collecting real-life stories about recertification and MOC nightmares. In the early part of this movement, first 1 or 2 years was spent trying to spread the word about the website and about the problems associated with MOC. In early 2012 was when I first met Dr. Benbasat, when he addressed the spring session of Docs for Patient Care, which was a grassroots organization of physicians. And he presented his concept of why MOC was a real dangerous program. While major journals continue to publish ABMS's self-generated articles without any conflict of interest declarations, we were being simply left to respond to them. Subsequently, a core group of physicians was formed in 2012 with representation from many states. In late 2012, an article appeared in the Journal of Clinical Endocrinology and Metabolism, which warned its readers of the potential effects of a new method of MOC being planned by the ABIN starting 2014. This really piqued my interest. Subsequently, the anti-MOC movement expanded. In early 2013, I joined another colleague of mine and established and created a survey of practicing physicians across the country. And within 6 weeks, we were able to collect nearly 700 physician responses to this question about MOC and its validity to practicing physicians. Not surprisingly, overwhelmingly, physicians in practice opposed MOC due to its lack of value. However, a majority of these respondents were actually participating or had participated in it because of work requirements. We were further astonished to see that a significant minority of physicians who answered the survey felt that MOC was a requirement for licensing. Just after this survey was completed in April 2013, I helped organize a debate on MOC at the University of Pennsylvania under the auspices of the Benjamin Rush Institute. We invited the ABIM to send a representative to defend its position, and despite being in the proximity of the venue and being given a 4 to 5 week advance notice and an honorarium, they refused to send any representative to this debate. This led us to believe that ABIM was truly not standing behind this product. Following this, we also surveyed our own patients and collected close to 800 responses. And we asked them what they thought about maintenance of certification and board certification. Again, not surprisingly, we found out that most patients are completely unaware of what board certification or pre-certification or MOC. All they expect is a physician who is well-trained and licensed in the state that he or she is practicing. Therefore, the grassroots movement took hold. Our group of doctors was then joined by an expert in non-profit malfeasance. This lady was obviously very interested in our cause because she had several doctors in her family going through the same harrowing experience of maintaining certification. Subsequently, we were able to establish a LinkedIn group and quickly spread the word around. We were also able to establish and set up a monthly anti-MOC newsletter, and based on the number of contacts that we had collected in almost 40 or 50 states, we were able to distribute timely information to all the contacts. In early 2014, Dr. Paul Kirstein, professor of cardiology at the clinic in California, set up an online petition challenging the ABIM MOC program. Within a few weeks, several thousand signatories had signed their names to it. The second petition was started by the same group, which asked the signers to promise not to engage in MOC, and that also gathered several thousand signatures. Thereby, our movement gained support. In May of 2014, my national association, the American Association of Clinical Endocrinologists, published its position statement on lifelong learning, which dismissed the concept of MOC based on lifelong secure exams and testing. Several state medical societies followed with their own versions of position papers on lifelong learning, and then the American College of Physicians did the same. All of them uniformly dismissed the concept of MOC. In the meantime, we were joined by two allies and leaders. One was a retired forensic accountant who had stumbled across the finances of the ABIM and was wondering why this was going under the radar. He contacted us through the website and then began working on ABIM's financial and accounting history. Also this time, Dr. Wesley Fisher, an Illinois cardiologist, electrophysiologist, had been publishing anti-MOC blog posts on his own blog for about a year, also joined our movement. And finally, this movement went on the offense. In 2014, several articles depicting the damaging effects of MOC were written and published in various online media. We were able to refute every article written by the ABMS and its affiliates. Several articles were published in blogs and even in the mainstream media such as the Wall Street Journal and the New York Times. An exhaustive list of such articles is available at changeboardresearch.com/anti-MOC. 2014 then ended with a great debate in Philadelphia where Dr. Chuck Cutler, debating with Dr. Richard Barron, destroyed the myth that ABIM is a benevolent professional organization. Links to this debate can be found at www.pamedstock.org. 2015 then was a brand new year in the anti-MOC movement. In January of 2015, Dr. Kirsten Heath, Boarded to Death, is published in the New England Journal, which created a huge interest in this issue as well as reaction from the ABIM. Subsequently, in the same month, Dr. Kirsten, along with a lot of other well-reputed physicians and surgeons, created an alternative board called the National Board of Physicians and Surgeons, in short, NBPAS. Just after that, in February, ABIM then issued a formal apology and then canceled Part 4 of the maintenance of certification process. By that time, MOC had gone mainstream. Mr. Kurt Eichwald, who is an award-winning investigative journalist for the Newsweek magazine, along with data supplied by our colleague who was the forensic accountant, published 3 highly critical articles in Newsweek in March, April, and May 2015. These demonstrated ABIM's crooked accounting tactics and devious ways of entrapping physicians in the MOC process. Within 3 months of its establishment, the NBPAS had certified more than 2,000 physicians. The moral of this story, for those of us who are working towards freedom in medicine, is as follows. Physicians are inherently risk-averse. They're ever willing to jump through hoops to just prove their mettle. Many large organizations are ever willing to enforce useless mandates and diktats on physicians simply because they have the power to do so. Patients and physicians have given up their ownership of this central location in healthcare universe, thereby creating a vacuum. And this vacuum has been occupied by all the middlemen that we like to call the troika, the government, insurers, hospital administrators, and boards. So what is the reality in the healthcare universe? Knowing that they cannot operate a system without physicians, the powers are actively recruiting mid-level practitioners to fill this role, such as nurse practitioners and physician assistants. The government, insurers, boards, and hospitals have created a self-perpetuating nexus that will not allow a physician to practice without meeting all the mandates and requirements. The government has even discouraged Stark law in order to encourage formation of large conglomerates or ACOs, or accountable care organizations, and coded into law the MIPS program, which will force physicians to share data with Medicare or with the government, and these are operated under criteria generated by the National Quality Forum, which is incidentally headed by the former president of the American Board of Internal Medicine, ABIM. So the key issues that I think are important are the loss of professional autonomy, loss of patient choice, protocol-driven medicine, now getting paid for data collection instead of being paid a fee for a service, being forced into risk-sharing contracts with third parties, even though we have no knowledge or experience with such contracts, thereby creating a moral and ethical dilemma for every Hippocratic physician. Thus, in the end, resulting in the decline of the profession and the death of the patient-physician relationship. So what can we do about it? The common perception is that this is a David versus Goliath battle. What our anti-MOC movement proves that it really isn't, because we, with our patients, essentially form the healthcare system. Everybody else is not integral part of it, but we are. So we should discard that myth. Secondly, we should also discard our own inherent risk aversion, knowing that anything worth doing will carry some level of risk. And if we are able to accept that risk in a calculated manner, we will achieve our target. Third is, we must accept our responsibility to be the force of change. We must join forces with our patients to force this change on the system. Working with them as their advocates, we should be able to achieve the target. However, it's important to understand that significant sacrifices will be needed. No big event or achievement is obtained without significant sacrifice. But if you familiarize with yourself with the facts, as we did with our MOC movement, we should be able to stand firmly on what we believe, which we know is true, and proceed along with our patients. But what we need to do is to get your staff and your families ready for a long battle, because this is going to be a long battle. Since nobody in power will voluntarily cede their power just because we ask them to. And finally, we must expect the usual response, which is being ignored first, then being vilified, then being threatened, and finally and hopefully victory. So what specific actions have I taken myself? My first action was not to participate in any ACO or risk-based contract. I have decided not to share my data with the government, which means I will not submit my computerized data to any government organization. I have certified with the National Board of Physicians and Surgeons and will relinquish my ABMS certificate when they expire. I have rejoined my state medical society, which I had quit about 8 years ago, so that I can actively engage in action to strengthen the private practice of medicine and change criteria for hospital and insurance credentials. Using the vehicle of a state medical society will be, in my opinion, very useful, because they have the ears and eyes of many policymakers. I've also engaged my specialty society, ACE, to force discussion on support for free market-based medical practice. As I was able to do in 2014, I was one of the chief authors of the position statement on lifelong learning. Thereby, we know we can achieve this in a piecemeal manner. I'm also very supportive of my colleagues, irrespective of where they are, who are struggling, and I try to help them remain in private practice. I also engage with local business leaders, including Chamber of Commerce and NFIB and others, to educate them about free market options for purchasing medical care for their employees or other businesses. I'm also surveying my Medicare patients at this point about my belief that Medicare is forcing unethical behavior from physicians. And thereby, I'm preparing to exit Medicare in the next year or so. I'm going to use the data from my survey to organize a town hall meeting and invite my elected representatives from the Senate and the House to engage in a question and answer session with my patients and myself. So what are the other actions that I would suggest to you, the viewer, and other physicians who may be in contact with you? If you are a primary care physician, you should seriously consider converting either partially or totally to a direct primary care model. There are several models available across the nation. Whitney Health in Florida, Atlas MD in Kansas City, Alliance in Washington State, Medline in California, Ideal Medical Clinic in various states, starting in Oregon. They're all examples of direct primary care models, which basically function like a subscription-based practice. And it's a low-cost alternative to concierge medicine. If you're a specialist, I suggest you connect with direct primary care practices in your area and offer cost-effective, high-value care in a timely manner. If you notice, I use the same phrases that the government uses: cost-effective, high-value, timely manner. But my cost-effectiveness and value is for the patient, not the government or the third party. If you're a surgical or radiological specialist, consider transparent pricing for all elective services. Offer discount for cash payment and work with direct primary care practices to achieve the same goal. For all physicians, I would suggest work on negotiating discounts for lab services, radiology services, medication on behalf of your patients, thereby creating a high-value proposition for your patient. I have done this in my own practice for about 4 or 5 years, since maybe even longer, seven years since the start of the recession, and a lot of my patients lost their jobs and their insurances. I was able to manage to get them effective, timely care at a very cost-effective, in a very cost-effective manner, and that's where I decided that this might be the best option for these patients. If we are able to put all these pieces together, I am pretty sure that patients will ditch their ACA mandated health insurance and purchase health care directly from the service providers. But it is incumbent on us to provide this as an option. So again, I would like to end my talk remembering the primary mission of why we are talking today. Number one mission is that physicians must be unfettered patient advocates. If we believe that, nothing can go wrong as far as I'm concerned. Number two, physicians must join with their patients to take back their central role in the healthcare universe, which I talked about earlier. There is no healthcare without patients or doctors. And number three, patients and physicians together must relegate the middlemen to the periphery of the healthcare universe, which is where they belong. This, I believe, will be an automatic result if we achieve the first two objectives. We get together with our patients and become their unfettered advocates. We will be able to achieve it, but we must prove that we were able to do this on the ground in every community. This, I believe, is the formula that we can use to achieve freedom in medicine. I hope I was able to bring this message home to you folks today. If you have any further questions, please feel free to email me at mdllcoffsice@gmail.com. Thank you for watching.
Good morning, Dr. Cavale. Dr. Thompson here. Can you hear me?
Yes, I can.
Well, thank you for joining us. Thank you for an informative presentation. I especially appreciate the actionable items, and I want to thank you for your leadership. I have some questions to begin with, but I'd like to ask Dan and Michael if they have questions that they want to start with.
Sure. I thank you again for your presentation. Really enjoyed it, and for everything you're doing for all of us in the medical profession, and for speaking out, your willingness to speak out and make a stand. I think we need more of that. I was struck by your comments that in order to achieve things in the medical profession, not only maintenance of certification, but we need to discard our inherent risk aversion and accept responsibility to be the force of change. So whether it's maintenance of certification, electronic health records, but you mentioned that. Could you elaborate on that a little bit? What do you see as the, well, just go ahead and elaborate on that.
Okay. Well, you know, my own practice experience that if we don't challenge the status quo and take a stand, then we really don't have a chance of winning. And what I have done, or what I've said in my talk, kind of mirrors what I've done in my practice. And essentially, I was like everybody else, 15 years ago, not willing to challenge the status quo, or in spite of the fact that I knew what I needed to do, I was more than willing to follow what the rest of the crowd was doing. But what I realized quickly was that that may not be enough. And since I would say 2002 or 2001, I decided to take a different course. And essentially, most of the convictions I had were proven correct. And till today, I'm still experimenting with various ideas that a lot of people tell me are not valid at this point. And I'm sure at some point in the future, it will have. So that's the basis of my conviction.
Thank you.
I'd like to ask what suggestions you would make to us to help us be effective in rallying other physicians around these types of causes.
I think the basic requirement is convincing physicians that doing things out of the box is not such a dramatic thing, and it's possible to do that by working together amongst ourselves and with our patients.
Arvind, I'd like to ask you about your own petition. How's that going? And with your permission, we'd like to link it on our petitions page.
Sure. Petition went really well for the first 2 months, and then it has slowed down. And I would say I have close to about 800 signatures, and we really like to see it shared amongst all different organizations. I'm sure the petition is very non-controversial and straightforward. So a lot more doctors, if they get access to it, will be willing to sign.
And so you're okay with us posting it or linking to it on our page?
Absolutely.
Okay, thank you.
Another question. Arvind, I have another question. In your own mind, when you said there was this tipping point where you realized that you had to do something different, as you look introspectively, what was that? What was the one? Is there one thing that said, I need to change, I need to start speaking out, I need to do something? What was it? What was that one thing, if there was one thing?
The conventional thinking was, and I'm saying this with very, trying to be as diplomatic as I could. The conventional thinking is that we have certain friends in the healthcare world, and what I quickly realized is that those entities that we thought were our friends are really not our friends. And one of the entities was the major hospital. And when I spoke to a lot of my colleagues about it, a lot of them are dependent on hospitals. And I got out of the hospital business in 2008. And I realized that it's 7 years now, and I got a lot of criticism for that because, I was the only endocrinologist in at least 3 of the hospitals. And I felt badly about it, but in order to change my course, I had to make that decision. It was also a financially averse decision, but I knew I could make up for it. But challenging some of the sort of well-held rules in medicine is probably the first step. And then, of course, the other part of the troika, which is the insurance companies and the government, soon follow. So since getting out of the hospital, I've also sort of disconnected with a lot of the insurance plans that really don't have a valid reason to be on.
Arvind, if you'll forgive me, when you were talking, it reminded me of a dream I had many years ago, where I was walking along a street. It could have been in Washington, D.C. There were a lot of marble columns. And I became aware that someone across the street in a suit and dark glasses was following me and watching me. And his head was turned as he was watching me across the street, so he kept running into these marble pillars. And it just made me think that, when you're watching someone else's business instead of your own, that's the kind of thing that happens. So while you were talking, I thought, the players in this game need to watch their own business and not somebody else's. The hospitals should be focused on making the best hospitals they can. The insurance companies should be focused on providing the best service they can, but not watching what the doctors are doing, something they've not trained and not experienced in and don't know how to do. And we need to watch our own business as well.
I have a question. You and Michael talked about a petition that you have, Arvind. Tell the audience a little bit about your petition and where to find it, please.
Sure. It's on change.org. And let me pull it up for 1 minute. Essentially, what I've always done is try to connect the patients with the physician and make them a single unit as much as possible. So the petition essentially does the same thing.
Okay.
Trying to open it up. So okay. The petition basically says that the title is Frame the Patient-Physician Relationship Back. And it just goes to show, it just has 4 points where the physicians, we as American physicians, want to return the relationship back to the center of all healthcare, and we should work with our patients and our elected officials to minimize the effects of third parties, the bad effects of third parties. And we want to bring freedom and choice back both for patients and physicians. So to that extent, we'll only allow our patients and not any other third party to decide on the value of the care that we provide. So that's all I say in my petition. And I think most people, reasonably thinking people, should be able to support it.
I would agree with you, and we'll promote that. So I have a question. One of your slides made reference to a second petition to not engage in MOC. Can you?
No, that was Dr. Pearson's petition.
Okay, and so I do remember Dr. Tierstein's petition. Did he have a second petition, or were you making reference to yours and his?
No, he had 2 petitions, one after the other.
Do you have any experience, or can you speak to the audience on the consequences of not participating in MOC at this point in time?
Oh, boy. I think it depends on your circumstance. If you're an independent practicing doctor like me and you have a good relationship with your patients, your community needs you, you probably will have very minimal impact of not participating in MOC. On the other hand, if you're a hospital employed physician or somebody who is an academic whose job title includes maintenance of certification as a requirement, then you're probably forced to participate. My hope is that the academic physicians eventually take this opportunity to perhaps certify with the National Board of Surgeons, so they don't have to do MOC. And just yesterday, in the Journal of the American Medical, there was an article written by Dr. Graham McMahon, who is the new head of the ACGME, and he writes about the value of continuing medical education. I can share that article with you if necessary. I think we should, as a physician group or group, try to work with ACGME to come out with relevant and pertinent CME programs that make sense to the practicing physician and does not involve repeated test takes.
Yes, please do share that article with us.
Sure.
I want to take this opportunity to extend a word of caution, perhaps, and once again solicit your input on the potential consequences at this point in time of relinquishing one's board certification in return for the alternative board, which we'll hear about in our next presentation. I just want to caution people not to leap too quickly without having all the information. Am I correct?
That would be right. Every person has to make his or her individual choice.
You know, I just wanted to say, in my own experience, I first board certified in 2005. I took the med study board course. I really enjoyed that, and I thought it really helped my practice in the coming years after that. And I was due to recertify, retest this year, and I've not done that yet because of being busy with this conference. But got the med study course again and really look forward to it. Now, you know, I understand that the pace of knowledge is picking up all the time, and maybe every 10 years is not enough. That makes sense to me. All of us, of course, have our CME requirements for relicensure every 2 years that we keep up with. And then there's the issue of the paywalls that block us from getting access to the raw data, the medical literature that we really need. So again, I believe if we are just given some breathing space and the opportunity, most of us are self-motivated and will keep ourselves up to date if we're just allowed to, rather than beaten into it and fleeced along the way. That's preventing us from keeping up to date, not helping keep us up to date. What do you think is the best way for physicians to keep up to date in the best manner possible?
I believe in my case, working with my own national association or specialty society gives me the best, the most efficient way of updating my. I find the concept of taking a secure test to be irrelevant. In my own specialty, you know, I'm gonna kind of shamelessly promote this online resource that I use all the time. It's called Endotext, and it's a textbook online. And you can search by topic and read up a chapter and take a test, and they will provide you CME credits for taking the test. And it's a great resource for endocrinologists. There's a nice section on all different subtopics in endocrinology, and it works beautifully. And I don't feel that after 20 years of practice, I need to sit down and, you know, in a secure environment and answer questions on a computer, perhaps half of which are completely irrelevant to me and my patients.
Correct.
So to me, MOC should be a purely voluntary activity, and secure test taking must end. If at all, if people require and they feel that they need a test, it should be an open book test. And that would be the best way to get your update as well as the knowledge retention.
Thank you.
Dr. Cavale, do you have a plan in mind for what your next step might be?
My next step is working with my Medicare patients now. I'm having some serious issues with how Medicare is trending, and with the last law that was passed in April, which is MACRA. And I believe by 2018 or 2019, since I do not believe in participating in data sharing or risk sharing with the government, I may become ineligible to participate in Medicare. So I would like to preempt that possibility by talking to my patients and asking them, what they feel about all this. So I started my own survey with my own Medicare patients to ask them this question. Would they like me to share their data with the government, or would they like me to share risk with the government in order to manage them? And I'm planning to have a town hall with all my patients and hopefully invite a few of my elected officials and ask them the same questions in an open forum. I think all of us should do that in our own communities and get comfortable engaging politicians and patients in the same meeting room, because ultimately the politicians are intruding in our exam room, so we might as well ask them to explain why. So that's my next step. And if I find that there's enough support among my patients, my step would be to opt out of Medicare next year.
Please.
Hey, Arvind, Dan Cravioto here again. Could you just clarify? I think I know what you mean by the term, but when you say you don't feel comfortable risk sharing with the government, spell that out. What do you mean by that?
Okay, so there is a proposal which is now part of a law, which asks us to engage in what they call an alternative payment model, or APM. Essentially, Medicare would like to share risk with the provider, so they want to engage in a contract with providers so that they can pay the providers a lump sum of money to manage the care for a number of Medicare patients. Could be 1,000 or 2,000 or 10,000. And the profit from all that money would be whatever is left at the end of the year from all the care that's given, minus the lump sum that has been paid. And in order for us to do that, we will have to become part of an accountable care organization, or an ACO, which is a conglomerate of all different types of providers: hospitals, nursing homes, pharmacies, etc. And essentially, it's the corporatization of healthcare or medical care. And I will be part of a corporate sector where I'll be forced to balance my clinical decision making with the keeping in mind the financial health of the corporation that I'm actually working for. And that's an ethical and a moral conflict of interest for me. So I would not like to engage in that kind of a conflict of interest. And I explain this to my patients, and most of them seem to understand. So as of now, in my survey, I have more than 110 responses, and I have about 67% of people who say, they will just pay me out of network to see me because they find that the value I offer them far exceeds all the other shenanigans I need to do in order to get paid. So it's a very gratifying feeling, actually.
Can I follow up?
Go ahead.
So, Dan again here. a lot of people, especially the federal government, have said there's a conflict of interest in fee-for-service as we know it today. In other words, you're rewarded for maybe ordering a test or doing a procedure, but don't you think on the other end of the spectrum with these ACOs and bundled payments, no one ever talks about this, there's a conflict of interest of withholding care. In other words, if you are rewarded by earning more money at the end of the year because services were not used as much, then the physician and the hospital or the entity are sharing in more revenue. Well, that seems to me to be a conflict of interest in withholding care. So in either system, if you're unethical as a physician, right, there can be bad apples in either system, but this now is going to direct it the other way, I think. Your thoughts?
I agree. You know, it's just, you know, ultimately, there has to be trust in the system. And as we know, and I'm sure you all know, Medicare is the only system where you're guilty and proven otherwise. And I mean, we can't run with that system. It's not practical. You know, our patients trust us, and I always, you know, I have no hesitation in sharing financial issues with my patients. And in fact, a lot of my patients, I'll give you a classic example. Just this week actually, I have a thyroid cancer patient who, for whatever reason, signed up for an ACA plan with the exchange, and he's now on a high deductible plan. And he needs a neck ultrasound as a baseline, you know, surveillance method every year. And so he goes to his local hospital, which is my hospital too, and they ask him for $600 for a neck ultrasound. And so he calls me up and says, "Doc, I can't do this. It's too much money. I'm just going to skip the appointment." And so I convinced him to look around and I give him a few numbers where he could pay cash and get a discount. So eventually he came to see me yesterday, and he got this study done at another imaging center for $150. And he was more than happy to tell me that, you know, thank you, doc, you directed me in a different to a different place. And I said, you know, if you had just shopped around, you probably gotten another $25 off somewhere. But he was happy to pay $150. So a lot of my patients are living. I just saw another patient who just retired from a pharmaceutical company about a half an hour ago, and as part of the retirement package, he was shifted to an insurance plan that I'm not part of. So he showed up and he gladly paid me my fee, and he didn't, you know, there was no doubt in his mind that he wanted to see me for the future. So I don't feel guilty about this because I really provided the level of care that the patient asks for, and if the patient pays for it, that's great. If a third party pays for it, I'm not beholden to the third party. So I think the care about fee-for-service is a little bit of an exaggeration. I think if patients are given the control of how things are managed, the care will eventually subside.
Arvind, I'm impressed with your efforts to engage your patients. How successful has that been, and what advice can you offer other physicians on that subject?
I would two parts of the advice. One is you should prepare yourself, in the sense you should know what your service costs you. What are the general costs of managing a patient? I see a lot of diabetics, so obviously I have a lot of lab work. I may have a few other studies like EMGs or things like that. I see a lot of thyroid patients, so I have ultrasound and lab work. So I've learned my lesson during the Great Recession in 2008, 2009. There were tens of patients, maybe up to 50 or 60 patients of mine who lost their jobs in 2008 and they lost their insurance. But these were patients that were seeing me for years, and they didn't want to give up on coming to see me. So I offered them a reasonable fee to see me, but then I realized there were a lot of all these ancillary services that they had costs for. And turned out I was able to talk to the National Laboratory, and I was able to get them discounts of up to 85 to 90% of retail costs. And I talked to a couple of my friends who were radiologists with independent radiology offices, and they were able to offer them up to 50, 60% off of their bill rate for simple procedures like thyroid ultrasounds or abdominal ultrasounds, peripheral vascular studies, echocardiograms, things like that. So I was able to get these things done and show these patients that if they really did well, followed my advice, and managed their disease carefully, they would probably not spend more than $1,000 a year, including medication. And I was able to hook up with a lot of online discounted medication outlets where they would either get significant discounts or they would get, for example, higher dose medications which could be cut in half and used as a smaller dose, for statins, for example, things like that. So we were able to manage these things in a substantially smooth manner. And then people heard of this and talked to their friends who had also lost jobs, and I actually got more patients who didn't have insurance. So instead of fearing the uninsured, I started to like the uninsured because they were willing to listen to me because they were spending their own money. I was able to give them a very nice offer of covering all their costs, and they were happy customers. And and so it worked out for about 6 years now since we've been doing this, and several of them have gotten jobs back, and they have insurances. Some of them have insurances that I don't participate with. You give me cash, and it still works out fine. So I think, the conventional wisdom of worrying about the uninsured is another thing we have to get rid of. We want to get people who are uninsured because we can work magic with it.
What about efforts to educate patients on some of these obstacles to care? I don't know your experience, but I presume many patients are unhappy with the basic current system, at least in my experience. But what do you think about your ability or our ability to educate them on these problems, to get them to stand up, speak out, to speak to their representatives, their insurance companies, etc.?
I take every office visit as an opportunity to educate. Couple of minutes, and I should say, sort of gifted in being able to talk clinical as well as educational stuff in the same breath, as well as finish my office work while I'm talking to the patient. But it works out quite well that when I explain to them that this is how it happens, now you would have gotten this test for $15, but now you have to pay $25 because that was your copay. Or you could have gotten this medicine for $9.99 at Walmart, and now you're paying $15 because that's your copay from your insurance. So people understand that. It's not a very hard concept for them. And so I make it a point to illustrate with examples how easily it can be done.
Dr. Cavale, would you mind to forward to us a copy of the questionnaire that you're using with your Medicare patients?
Sure.
Okay, thank you. And may we put it online to share with other individuals?
Absolutely.
I also want to say, again, I'm a general surgeon, and not long ago, I picked up a patient through the emergency room who needed a cholecystectomy. He had other comorbidities. He was in his 70s. He had Medicare and a copay and a direct-to-practice primary care physician that he paid. And I asked him, why, when you have Medicare and a copay, do you also see a direct-to-practice physician? He said, because he spends time with me, he listens to me, all the things that you've just said. So that was just bringing the message home for me. I also, as a general surgeon, see a number of cash pay patients in the fashion that you have described, and we have found them, as you said, to be engaging, responsible, grateful. It's a gratifying practice. I'm actually looking at maybe having a blended practice, keeping my private practice as a cash pay option, and maybe being employed part-time through another option to continue to see managed care patients, so to speak. It's about time for us to wind down. Do you have anything that you want to say before we go, Dr. Cavale?
I think my message is very simple. Engage your patient, be confident about what you do. Don't undervalue yourself, and provide a solution. Don't just be a complainer. I think solutions come from the ground up, and our patients and us, we are the ground up force. So if you can engage your patients, they will be the best source of support to the community and independent physicians, and in fact all physicians. So that would be my message.
Arvind, I want to remind everybody we do have a section for patients, and we'd love to hear from them, both their problems and their suggested solutions, as you say. So if they go to letmydoctorpractice.org, scroll to the middle of the page, there's a section they can click on for them to contribute, and let us know what they think.
Thank you, Arvind. Good to see you.
Thanks.
Thank you.
Next time.
Thank you.